Thank you everybody for participating in Color of Poverty, Color of Change webinar. It's called Race Matters, Now Make It Count. My name is Samia Hassan and I'm the Executive Director of the Council of Agencies Serving South Asians. And CASA is also a member of Color of Poverty, Color of Change Steering Committee. Before we get started, I do want to take a few minutes to go through some housekeeping items. I'm just going to briefly share a PowerPoint here. All right, so a couple of things that I wanted to go through. So troubleshooting, unfortunately, we're not able to troubleshoot your audio and video connection during the webinar. If you can please check your own equipment and your connections and review this information in your registration email or the reminder email in order to do some troubleshooting on your end. If nothing works, what you can do is you can leave the webinar, you can exit the screen, and then you can try to log back in. Sometimes that works. Sometimes even restarting the computer or the machine that you're using can solve some of the problems too. Questions for panelists. We have a lot of people signed up for today's webinar, so close to 500 people may be signing in today. So everyone will be muted to help us manage things properly and make sure that the program runs smoothly. Please use the question box. So if you see the PowerPoint that I have shared, the question box is in the left panel, sorry, the right side panel, and you can type any questions throughout the session and we'll try our best to address them as best as we can. So the questions can be for us or for the panelists. The question and chat box, again, is located in your right side in your dashboard. And the chat box is separate from the question. So if you want to chat with the organizers, you can do that. But the questions that you have for the panelists or for Color of Poverty should be in the question box. And that's the box that I will be moderating and looking at in order to refer your questions to the panelists. And you can type your questions at any point throughout the webinar. I will be reminding folks to type in the questions after the presentations as well. Handouts, so we have 5 handouts that are already uploaded, again, on your right panel. So as we talk and even after, you can download these 5 handouts. You can use them later on. And you can reference them throughout my opening as well as the other presentations. If you have trouble downloading them, we will be providing these handouts in the Color of Poverty website. And so I'll ask my colleagues if they can send the Color of Poverty website in the chat box to everyone that will become available to you. We are recording this webinar. It will be available in colorofpoverty.ca. That's the website, colorofpoverty.ca. Some of the PowerPoints will be available, not all of them, on the Color of Poverty website. So if you need to refer to the PowerPoints afterwards, you can do that for some of them. But the entire webinar will be recorded and posted in the Color of Poverty website. So that is my few minutes of housekeeping items. We are going to be doing a territory acknowledgement before we start. And I am. So we recognize that where we are hosting this virtual gathering from is on the traditional territory of the Huron-Wendat, the Anishinaabe Nation, and the Haudenosaunee Confederacy, and the most recent stewards of these lands and territories, the Mississaugas of the New Credit. These lands and territories are part of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Anishinaabe, the Allied Nations, and the Haudenosaunee Confederacy to peaceably share and care for the resources around the Great Lakes. More recently, these lands and territories have also been covered by the Toronto Purchase and Williams Treaties between First Peoples and the Crown, the Settler Society, and more generally. In addition to the Mississaugas of the Credit River, the Toronto area is home to many Indigenous peoples, First Nations, Inuit, and Métis. We are grateful for this opportunity to meet, work in a good way, and recognize that there are locally relevant land claims negotiations still underway. At a minimum, we respect to the title in the Toronto Islands. With this in mind, we together set an intention and commitment to approach our work in a spirit of solidarity with respect to the full recognition of Indigenous rights and title, sovereignty, and self-determination, the acknowledgement and honoring of treaty-based settler obligations to help further the work of real and meaningful reconciliation, equity, and racial justice. So again, my name is Samia Hassan, and I'll be moderating today's session. So a bit of a background about this session today. So we wanted to do a session on disaggregated race-based data collection, specifically to health. And we know that race matters when it comes to health or any other social indicators of well-being and life chances. But we also know that Canada does not collect race-based data in health and in other areas. We have seen recently, as a result of COVID-19, that there have been some loose announcements from politicians about collecting race-based data for COVID, but right now there's no solid commitment. There are, as you may have heard, some public health units in Ontario that are sporadically starting to collect some data, but it's not a coordinated provincial or federal approach. And Color of Poverty, Color of Change is hosting this public discussion to consider why, first of all, we should collect race-based data in health in Canada, and who should collect it, what are the challenges in collecting it. And we have a panel of 4 speakers today who will let you know what is happening right now in Canada with data collection in the environment, who can benefit from the race-based data collection, and we can reflect on the role of who is collecting data, how they're displaying the data, who is reporting on it, which community groups are represented in this data collection, what are the health institutions are doing, and what role should the health institutions and government play in the collecting and releasing and reporting of data. Color of Poverty's position on a disaggregated race-based data collection has been clear. We know that disaggregated race-based data collection should be made mandatory for all social indicators of well-being, and reporting of this data should also be done in a disaggregated way and made public free of charge. And it's also imperative as the first step in addressing racial inequities in all its forms in all sectors, especially in healthcare. So today we are focusing on the healthcare piece, but the stance of Color of Poverty, Color of Change is that disaggregated race-based data collection should be mandatory for all social indicators of well-being. And you can take a look at the attached handouts that are in your left panel from Color of Poverty to get a better understanding of how data helps to illustrate these disparities and provides a rationale for immediate and coordinated action to address racial inequities. Our call is specifically for disaggregated race-based data because we know that even within the same communities, same racialized communities, there are unique lived experiences. There's differences in how poverty is experienced, and people face distinct barriers. So even within the same racialized communities, we can have variances in terms of the poverty people are facing. We can have variances by ethnicity, by gender, by age, and other biological and social identities. So, it's clear that why data is needed, why data needs to be collected, and why it needs to be disaggregated and race-based data. So I think you've heard enough from me for now. So I'm going to turn it to our panelists. So we have, first we have Marc Lachance. Am I saying your name properly, Marc?
Yes.
Okay.
Thank you.
So a brief bio of Marc before he takes the floor and presents. Marc Lachance earned a Bachelor of Mathematics degree from the University of Ottawa with a specialization in statistics in 1988. He started his career at Statistics Canada as a methodologist and then worked in the social statistics field, focusing on education and the labor market. Mr. Lachance is the Director of Diversity and Social Cultural Statistics, overseeing several statistical programs related to immigration, ethnocultural and linguistic diversity, Aboriginal peoples, gender-based analysis, disability, and general social issues. Mark is also currently the Acting Director General of Justice, Diversity, and Populations Branch at Statistics Canada. So I'm going to welcome Mark, and I'm also going to show Mark's presentation. There we go. Go ahead, Mark.
Perfect. Thank you so much. Can you hear me well?
Yep.
Yes, perfect. Thank you. So good afternoon. So I want to thank, first of all, the Color of Poverty for inviting Statistics Canada to this presentation webinar. Today, I know I just have about 8 to 10 minutes maximum. It's as a statistician, there's so much information, so we'll try to summarize in a few minutes. But what my presentation will be for the purpose of today's conversation, we're mostly to give you a quick overview to where we have been in Statistics Canada in the collection of disaggregated data. And as a statistician, I'm going to show you some of the findings so far, but also what we've been doing during the pandemics, but also some of the challenges, as you mentioned, Sami, at the beginning of the conversation. There are some challenges in collecting data, disaggregated data for meeting the needs of the communities, and also during the pandemic. So I'll talk about some of the challenges and maybe having a conversation, and hopefully with the questions the panelists will have, and also the participants. So next slide. So I'm just going to go to next. Perfect. So I just want to give you first a view. So Statistics Canada is leveraging, during this pandemic, we're leveraging what we call the Center for Gender Diversity and Inclusion Statistics. It's a center within Statistics Canada that has been created a couple of years ago, specifically to address the need for disaggregated data. So before, my apologies, I have the phone that just ringing here in the background. Just like, forgot to turn it off. My apologies. This is the beauty of working from home. So as I mentioned, is that the center was created to do 3 things, and to be accountable to Canadians, we want to report indicators of progress in all perspectives of the disaggregations. Either this is by ethnocultural, people with disability, LGBT, and so on. So what we want to do is to provide some information to the Canadian about the disaggregation. Another thing also is to generate new information. So what we've been doing for the last 2 years is to provide some new informations, new insight on the analysis of the data, or the disaggregated data. And one of the important things is around the standardizations of data. And so also as a third thing is that we're helping organizations to advance what we call statistical knowledge, statistical literacy, by providing what we call GBA plus training, helping other organizations and how to collect data, how to analyze properly. Next slide. Okay, so the next few slides, I will be very quickly. It's very rich of data, but I'm not going to go through all those data points. What we wanted to show is that, as you probably, Sami, you said in your beginning of the presentation, is that we know that there was inequalities in health, in the labor market outcomes, social economic outcomes. And we know that there was a lot of those conditions, those inequality existed before, and we have a lot of data. So I'm not going to go through all of those, but in that slide we show some of the health conditions on life expectancy, and we know that there are some communities, Indigenous, LGBT, that were probably more at risk in prior to the pandemic. And so we'll go to the next slide. And specifically, as the slide shows, that we know that the First Nation people with Indigenous identity, also we knew that they were a bit more at risk before the pandemic started. So what Statistics Canada has done is that we provided a lot of new information and new insights to our website to provide a little bit of a portrait to what was the situations of all our subpopulation, the most vulnerable prior of the pandemic. So we'll go to the next slide. And as I mentioned, there are certain groups, homelessness, people that are more at risk, people in shelters, and that side we saw also some statistics about some other groups, youth, Indigenous people, women, families, We know there's some higher rates of mental illness, addiction with people with disability, and we know also that some individuals with LGBT were a bit more vulnerable before the pandemic. Next slide. And what Statistics Canada has done since the pandemic started is that we put together some new data sources because we know that people wanted to understand the impact of what COVID had on some of those populations, either it is health or other activity or other domains. So what that slide shows here is that, as no surprise, there are some of the individuals, some other vulnerable population that are mostly impacted by the COVID-19. In that slide, we show that, no surprise, that mental health especially impacted the most vulnerable groups of the population and also healthcare providers. So on that slide, people have access to this information. They can also go to our website and get some more details about how specifically some of those subpopulation has been impacted by the COVID. So what Statistics Canada has done is that we have covered, we're doing currently some surveys. It's called crowdsourcing, some web panel surveys. And we also have put some variables that will allow us to do the proper disaggregations of data. And I can mention at the end of the presentation how we are collecting this information to ensure that the disaggregation meets the need of the analysis. Next slide. So this is where I would like to spend a couple more times on the challenges we have. So in that slide, what we're mentioning is that one of the challenges, and I think some of you almost referred to this a bit earlier in your beginning of the presentation, is that when it comes to disaggregated data, one particular challenge is to ensure that the system, how we collect the data, is done in a standard way so that we can compare the data in a proper way. Especially in the health side, especially at health, just like education and justice, relies a lot on provincial and territorial jurisdiction. And in case of COVID-19, we know the health authorities are starting to collect this information. So one of the challenges that globally, as all partners have, is to ensure that how the data is collected at the beginning by the respondents or by the institution is in the proper way. So one of the things that StatsCan is doing is that we are working and jointly with provincial ministry, territorial ministry, but also with health authorities to help them to provide some standards or guidelines. We're working also with CAI and other organizations to see how we can ensure that the way that information is collected, even though it's done by different institutions, it's done in a standard way, specifically when we talk about ethnocultural identities. Another also challenges for us when it comes about disaggregation of this data is to have the proper sample size. We know the census is the database that you can have all the disaggregation that you need, but many of our surveys do not have necessarily the sample size to be able to do this. However, Statistics Canada has committed themselves to provide more information on disaggregations. Very soon, we're going to do a new survey on discriminations and also around it's called the general social surveys. And we have, thanks to Canadian Heritage, we received some funding to do an oversampling of the ethnocultural group so that we can maybe address some of the informations. Another good news also I can share today is that the labor force survey, which is one of our major labor market indicators, starting in July, will start to collect information about ethnocultural individuals, so that it will be a very rich data set that we can follow. Next slide. And finally, I think one of the challenges that I'd like to talk about, not challenges, but things to how to move forward, is how we can work together as communities, as partners, to ensure that the disaggregated data really meets the need of the communities. In that case, what Statistics Canada is doing is that, especially at the time of the pandemic, we want to make sure that the data that we provide is real time, is relevant. We don't want to wait for several months before the data is available. And what we want to do is to work with partners, with health authorities, with provincial ministries on health data to ensure that we can leverage any kind of data and any type of sources. Surveys is obviously Statistics Canada a major way of collecting the data, but we also have administrative data in CSIS Canada. We can have access to data that we can link to other formations to be able to do the disaggregated. We also can create some new crowdsourcing information. In fact, this week, starting tomorrow, we're doing a crowdsourcing application on people with disabilities, in which we also ask questions about a population group, the cultural, the fact is immigrant or not. So those kind of new initiatives we put in place are going to be very key. You know, we're doing a lot. Is that enough? Probably not. I think we need to move forward. We need to work together to see how we can provide more informations. And this is what CSIS Canada is committed, because we are accountable to Canadians, we're accountable to communities to ensure that the data that we are collecting is meeting the expectations. So I'm going to stop there because otherwise I'll be spending more time, but I'll be able to answer any questions.
Great, thank you, Mark. So just a reminder that we will be coming back to the audience after the remaining 3 presentations for questions. So if you do have any questions, please, for Mark, you can state that the question is for Mark and just type it into the question panel on the right-hand side. So next we have Dr. Notisha Masakwa. Can you, Notisha, just remind me if I'm saying that properly? I think Notisha might be on mute. That's okay. We'll figure that out in a bit. So with Dr. Masakwa, she actually will be leaving the session a little bit early. So for her, we have allocated about 10 minutes after her presentation for folks to ask her any questions if they have any questions for her directly. So I would highly recommend, if anybody has any questions for Notisha, please put them in the question panel on the right-hand side, as she will be having to leave a little bit early today. Dr. Notisha Masakwa is a highly respected subject matter expert in health equity, anti-Black racism, and the designing of programs and services which aim to increase access to primary health care for Black women. During her lengthy career, she has facilitated the development and provided leadership to several health organizations and programs for Black communities, including Women's Health and Women's Hands, which is the only community health center in Canada which specifically provides primary health care for racialized women. Her research and numerous publications have focused on the use of health equity data to improve health outcomes for Black women, as well as the impact of racism on the health and well-being of Black communities. Notisha is the co-chair of the Anti-Racism Advisory Panel of the Toronto Police Services Board, which was recently responsible for producing the first mandatory race-based collection policy for a police service in Canada. Please welcome Notisha. Are you, you might be on mute. Let me try to help you there. Are you able to find the unmute button?
There we go. Hi, sorry about that. That's what you're always worried about, the technicalities. I want to thank COP-COC and the Color of Poverty in particular for the years of support in our advocacy around the collection of race-based data. I have a few slides that I'm going to share with you to open. But as someone who's worked in the healthcare system, particularly with racialized women, we would not be able to do our work if we did not collect race-based data. And so during my time at Women's Health, Women's Hands, 21 years, we've been collecting very specific race-based data so that we could better serve our clients. What I wanted to show is an example of why it's crucial to do this work. And if we can see the slides. Fantastic. So during my time at Women's Health and Women's Hands Community Health Center, one of the things that we noticed were the high rates of HIV that our clients were presenting with, and particularly our Black clients. But there was nothing to really show us that there was a pandemic that was very specific to Black women and what it looked like. And so we approached the Public Health Agency of Ontario, because one of the only areas where we actually systematically collect race-based data, and maybe it's not the best, but it's one of the most comprehensive areas, is in HIV acquisition. And so we approached public health because we couldn't figure out why we were seeing such a large overrepresentation of women, Black women in particular, with new HIV infections. And so this was the data that we were given. Between 2006 and 2015, you could see, particularly in 2015, there were 842 new cases of HIV diagnosed in the province. If we can go to the next slide. If we desegregate that data based on gender, you can see that men, and it was only male and female, a binary desegregation in terms of gender, that men were 676 of that population and women 162. And most of our HIV programs are based on this data, this modeling of data. So we see a lot of services that are targeting men in particular. We do not have a women's HIV clinic in the entire province of Ontario, and we have little resources that are very specific to women. So this wasn't actually talking about the level of HIV that we were seeing in our health center. We have the largest number of women living with HIV in any community health center in the province. We have over 600 cases. So I asked them if they could desegregate this data based on race. And if you go to the next slide, what you see is something very interesting. When we look at the African Caribbean Black population, the split of HIV was almost 50-50 between men and women, which is very different when it wasn't desegregated based on race. This tells me something is happening differently in the Black community in terms of HIV and the work that we have to do in terms of engaging these populations. When I asked them to desegregate the data based on gender and race, if you can see the next slide. For all of the women in the province, so we looked at all of the women who were testing positive for HIV, Black women are grossly overrepresented in particular. If we look at Toronto Central, where we're located, 70% of all new HIV infections between 2011 and 2015, they made up 70% of that population if we looked at gender and race. If we look at every health region across the province, no matter where Black people lived, Black women in particular were making up, in the central region, 66% of all new HIV infections in the province. Central East, 70% of all new HIV infections in the province. This is just a very simple example of showing you the importance of desegregating data. This not only explains what I was seeing for Black women accessing services at Women's Health and Women's Hands, but it also tells me how I engage in prevention programs, how I lobby for resources, and how I'm actually monitoring what the rest of the system is doing to support racialized communities. And I mean, we could look at all different types of chronic illnesses, stress-related illnesses where racialized communities are overrepresented, but we don't have systematic data collection in the way that we do for HIV. Unfortunately, the purpose of race-based data collection in HIV was about surveillance, and we have to acknowledge that. And you know, I want to emphasize that there are two barriers in terms of race-based data collection, two major barriers. One is political will. So we saw legislation being passed that is looking at the collection of race-based data for all provincial government bodies, with the exception of health. And at that time, when that legislation was being developed, we were lobbying extremely hard for health to be included in that legislation. We were told at that time that in order to get this passed, there wouldn't be enough time to address the privacy issue and the privacy legislation. So it's something that would be circled back around once this legislation was passed. We have not seen that happen. Sometimes people think it's not being collected because there is a privacy issue. No, there are things that would have to be worked through And we have very stringent privacy legislation in our province, but it's nothing that can be not worked around when we understand the severity of the situation for racialized communities and poor health outcomes due to the social determinants of health. The other issue that we have to address from a community perspective is the fear that community members have about the collection of this data. And people always ask me, you know, what do you say to community members who do not want more of their personal information, particularly racialized communities, in the healthcare system? It's a piece of education. Number one, we are already collecting an enormous amount of information about all of us, particularly those of us that have status in Canada and that have OHIP. To add race when you already have my address, my gender, I mean, all kinds of other things that we give automatically when we're seeking services, it's not going to increase, I think, the issues that people are worried about in terms of poor treatment. What we do know, however, is that without this information, what will continue happening is the poor outcomes that we're having in terms of accessing healthcare services, as well as receiving proper services, as well as our issues being addressed effectively because we don't have that information. There was an attempt in the last couple of years for the hospitals to start collecting race-based data. And my comment to them, or my advice to them, was the tagline that you're using, we are asking because we care. That was the campaign. We're asking you about your race, your sexual orientation, and other social demographic pieces of information because we care. If the medical system has not shown us in any way that it cares, I'm not going to now all of a sudden hand over this information that you're asking without giving context. We know that many communities have actually been harmed in the healthcare system, and this is the fear. This is the fear that people have. This is the fear of people engaging in research, for example, because it has been used to harm us as racialized people. So I do want to emphasize the importance of the collection of race-based data. Many of us that have been doing community-based work have been using it to effectively work with our communities and to address the social demographics, the social determinants of health, and that we do have to move this forward, but we have to address legislation barriers as well as community fear. And those are the three things that I think I would like to leave you with today.
Great, thank you so much, Natisha. I can ask everyone. There we go. Okay, so we so far don't have any questions for the panelists. So what I'm going to do is move to the next presentation. And keeping in mind your time that you have to leave, Natisha will, if any questions pop up before then, we'll let you know. If not, then thank you so much for joining us today. We do have the remaining 3 panelists here until 4:30 for other questions. Thank you. So next we have Dr. Anna Bannerjee presenting. Dr. Bannerjee is a pediatric infectious and tropical disease specialist. She has trained in Toronto, Ottawa, Montreal, and Harvard University, where she completed her MPH in International Health. She is currently the Continuing Professional Development Chair for Indigenous and Refugee Health for the Faculty of Medicine at the University of Toronto. She is the co-chair of the Indigenous Health Conference. She has been studying low respiratory infections in Inuit children for about 25 years, where her research has led to changes to national guidelines for the prevention of RSV. Dr. Bannerjee is a past member of the CPS First Nations Inuit and Métis Committee and has traveled to Indigenous communities across Canada. Dr. Bannerjee is also very involved in refugee health, where she currently chairs the North American Refugee Health Conference, the largest refugee conference globally, and her clinical work primarily focuses on refugee children. She uses a human rights framework for her work, research, and education, is often an advocate for vulnerable populations. Thank you so much, Dr. Bannerjee, for joining us. You are on mute. You're still on mute, Dr. Bannerjee. There we go.
You hear me?
Yep, perfect.
So thank you for the opportunity. And it's a privilege to be among such smart, passionate people. So I was asked 3 questions. And the first question is what's the public perception of race-based data collection? And what are some of the ways to do, I guess part of it was cut off. So I think that race-based data is really critical to understand the playing field and who gets what. And what's, I think, more important to me is why do these disparities exist? Race-based data shows or amplifies the systemic biases in our system, biases in access and privilege. For example, we know that Indigenous peoples are more likely to be involved with the justice system, but it doesn't ask us why and what can be done to reduce the risks. We know that Black youth in Toronto are more likely to be stopped by police, and that COVID disproportionately attacks minority groups. But again, it doesn't really explain why, and so I think we need to look a bit deeper. Then the question was, what are specific issues and concerns for Indigenous communities in the collection of race-based data? And as Notisha was talking about, there have been a lot of harm done in the past, especially with research done on Indigenous peoples without their consent or knowledge. And usually the research benefits the outsiders that go in, do their research, and leave, do their PhD, but the communities don't benefit. Again, a lot of this was done without informed consent. There are nutritional experiments done on Indigenous children in residential schools by withholding food to see what certain nutritional deficiencies what conditions would result with certain nutrition was withdrawn from children's diets. And this information was used to create problem. So that's one of the things where we let children starve and we benefit off of that research. Because of systemic racism, there is the perception that someone would be treated differently if their race was disclosed. For example, someone who may not look classical Indigenous may not want to declare their indigeneity, because if they do, they're more likely to be treated differently because of systemic racism. And we know for a fact that the care of Indigenous peoples is much worse than that of non-Indigenous peoples. Again, some of the data that Mark looked at, you look at mortality rates, you look at infant mortality rates, you look at education rates. Basically, in every aspect, Indigenous peoples, their vital statistics are lower than non-Indigenous peoples. And then one of the questions were, how are data being used or not in designing healthcare for Indigenous populations? So I'm going to go back to data collection is really important, and that tells us, what are the differences. And I think that's really important is that we use data for the implementation of fair and equitable policy. And so I believe that we live in an apartheid state where access to resources depends on your race. So you have Indigenous people, and if you're Indigenous, you get a certain amount of money for school, education, health, which is a fraction of what non-Indigenous people get. And based on that definition, that's called apartheid. When you're looking at data, do we need to study and prove that clean water is good for health? Don't we already know that? Isn't there enough data there that says that clean water is good for health? It's one of the lowest parts of Maslow's triangle, saying water is good for us. It's a cornerstone for health. Yet we still currently have 56 First Nation communities that don't have access to clean water. That has gone down in the past few years. If we had water damage, or someone built a dam in Hyde Park and it flooded the Grenadier Pond, and because of that we had mercury outbreak in Hyde Park area, how long do you think it would take for them to clean up mercury? Probably a few days, few weeks. Yet in the 1970s, when they dumped pulp and paper barrels into the water and caused mercury toxicity and killed and injured many people, decades have passed. It's more than 50 decades, and they still haven't cleaned up Grassy Narrows. The chief recently died of mercury toxicity in Grassy Narrows. RSV is a respiratory virus that puts babies in the hospital with lung infections, babies all around the world. There exists a vaccine, an antibody, that's given to children at high rate of admission for RSV all around the world. Supposed to be the most vulnerable children. However, Inuit babies have rates of RSV higher than any of the other risk groups, basically premature babies and cardiac babies. And Inuit babies have to be flown down, so they have additional risks of being flown down. There's additional costs of the medical evacuations, and when they end up in the hospital, they are separated from their families. But despite the evidence that shows that these babies have these really high rates of respiratory infections, we've seen that for over 10 years, these babies still don't get the antibody. So it's not just data. Even when the data exists, we still have systemic racism. We started a petition on this back in fall. My classmates started a petition on that. Despite 130,000 signatures, the Inuit babies still don't have the RSV antibody. We have food insecurity in Canada, which has a great impact on children and youth. We have, in some Indigenous homes, in the food insecure homes, we have stunting occurring, where the food insecure homes are at least 2 centimeters shorter than the food secure homes for the children. And so in Canada, because again of the systemic bias and racism, we allow this to happen. COVID could be devastating to Indigenous communities, and we've been observing this devastation in Navajo in the United States, and also in the Indigenous communities in the Amazon, where the communities are starting to become decimated. Many remote Indigenous communities have water and food insecurity, people living in overcrowded houses. Indigenous people have the highest rate of underlying health conditions, heart disease, diabetes, cancer. Putting it all together, it means that Indigenous people in Canada are at high risk for serious COVID infection. But we don't have a systematic way of tracking COVID in Indigenous communities, especially in urban Indigenous populations. And this data, and it is not being collected. And if it is collected, it would not be collected in a timely fashion to make a difference. I would say that we need new development, Millennium Development Goals for Canada, maybe call them Millennium Development Goals for 2030, where we say that all Indigenous communities need Millennium Development Goal 1, access to clean water. Millennium Development Goal 2, access to food security, or a national food security strategy. Number 3, equitable access to education. MDG Goal 4, equitable access to social services and education, and equitable access to safe housing. I would say to you, even if we have race-based data, unless we address the racism and the systematic discrimination, then we only have half the solution.
Great. Thank you so much, Dr. Bannerjee. So again, a reminder, Natasha did have to leave for a personal reason, but we do have some time around 4 o'clock for questions for the other panelists. So it would be helpful if you have your questions now, if you can start populating the question box so that we can start organizing the questions for the Q&A segment after the last presentation. So thank you so much, Dr. Bannerjee, for your presentation. We have one last presentation from Amy Go. Amy Go is a social worker by training and has years of experience working with immigrants and seniors through Whit Green Community Center and the Yi Hong Center for Geriatric Care. For over 3 decades, Amy has advocated for social justice as well as rights of women and racialized community. Currently, she is the president of the Chinese Canadian National Council for Social Justice. Amy was involved in the campaign that successfully obtained redress for the Head Tax and Chinese Exclusion Act. Amy received the Woman of Distinction Award from YWCA Toronto and Immigrant Success Individual Award for Outstanding Innovation and Achievement in Promoting Immigrant Inclusive HR Practices from Toronto Regional Immigrant Employment Council. Amy is currently working as a consultant supporting health and social service organizations in strategic planning, program development, reviews, and evaluation. Thank you, Amy, for joining us today.
Thank you. Thank you very much for this opportunity. So the focus of my presentation is on long-term care, and long-term care actually is interesting as compared to the other healthcare sectors. And we've heard a lot of stories about the devastating impact of COVID-19 in seniors, in particular, those that live in long-term care. Over 80% of the deaths are attributed to these the high mortality rate experienced by these seniors. So, and it's really, and when you see all the media story, in fact, you will see that most of the people that were interviewed, basically the residents' families are usually white English speaking. And also the unfortunate thing when you see the other side, the frontline staff, particularly the PSWs that have passed away due to COVID in the healthcare and in long-term care, people of color. And that is the reality, that most of the long-term care residents, even though I do not have the data because we have never seen any such data, but I would say quite confidently that the majority of the residents in long-term care in Ontario are of white Caucasian English-speaking seniors, but not the frontline. The frontline staff in PSWs and food services and facility are probably overwhelmingly from racialized communities. And there are a few very small number of homes in Ontario that provide we call culturally appropriate care, such as, Yi Hong Center, specifically dedicated to Chinese Canadian seniors. And so if we try to look at the disaggregated race-based data within long-term care, if we're talking about resident care, then we're going to see mostly white, English-speaking long-term care residents with the small pockets that are from racialized communities. The reason is that, first of all, because of the inequitable long-term care sector, and that the sector has not been responsive to the needs of racialized seniors, particularly those who don't speak English, whose cultural practices are not being addressed and recognized in these homes. And so because of this systemic inequities, that seniors from racialized communities would choose not to go to long-term care, and long-term care should always be the last resort. So having that as a backdrop, if we look at the segregated data within long-term care, first of all, previously it was the CCAC, and now they're called LINS, and now they're called Ontario Health Ontario. They do collect data when they ask the applicants, when they apply for long-term care home, what language do they speak, and the ethno-racial background, because it's noticeous that actually the law, the Long-Term Care Homes Act, stipulates that long-term care homes have to be responsive to the needs of the residents, be it their cultural practices or their religious practices and all that. So they do ask. However, though, again, as I said, how are these data being used in analyzing or even in providing care? is highly questionable, except of course in cases where homes are specifically dedicated to these racialized communities. So when we're talking of collecting this data, we have to bear that in mind. And so it would not be hard to have that data in your hand and be publicly accessible because it's collected. And it is also important to note that long-term care homes are required by the Ontario government to have clinical data of the residents. So, and because these clinical data are used to determine the funding level of the long-term care homes. So, and also Health Quality Ontario collect these data to then reflect on the clinical outcomes of each of the homes. For example, what's the prevalence of skin breakdown, wound care, what's the breakdown of falls and responsive behaviors, and all those clinical data is being analyzed and collected and being actually publicly made accessible through Health Quality Ontario. However, they are not disaggregated according to the race and gender of the residents. And let me also say that I'm not sure that the long-term care homes do ask about gender identity, but they are homes, again, a very, very small, probably one, that I can think of that dedicate itself to provide care to the LGBTQ 2S communities. So while the data is available, and in terms of race-based data and clinical data can be extrapolated and is available, but how do you then analyze and break them down according to race and gender and make them, and the performances of the whole overall sector? But as I said, because the overall sectors, I would think it's overwhelmingly in terms of the resident population represented by the white English-speaking communities. And so if you further break them down within the sector, then you are probably comparing with the very small number of homes that provide, racialized senior services, and then the majority. So it may be actually more important to look at then sort of like each home to have to ask each of the home to break it down so that they can do the analysis, and they should have the tools to understand whether their care has led to differential impact, whether the racialized communities, or it could be small communities within that home, are not experiencing the same outcomes or same service as they should, as compared to the predominant groups within that sector. So when we look at long-term care and senior care, we have to look beyond long-term care. We have to look at the barriers and people, why don't they go to long-term care, and also what are being available to racialized seniors in the community. So data in community care is important. And community care, there are publicly funded community care services, for example, nursing, personal care, and others that are provided to seniors in their own homes, or in senior housing, or even in retirement homes. And this, to me, that data is important, and to be able to break them down according to who are getting the care, what's the frequency and the volume. Again, as I mentioned, because most of the racialized seniors do not go to long-term care, even when they are in such dire needs for care, they probably are still being cared for by their own families and not accessing the public system, while the public system should be accessible to them. And so I think it's important to, in fact, demand that kind of breakdown from the community care service vis-a-vis Ontario Health, so that we know who are getting publicly funded community care and who are not. As well, then if you look at the impact of care, so we know that, as I mentioned, in long-term care, they are required to collect data, including rates of infection, upper respiratory, lower respiratory rate, infection rates, wound, as well as bladder infection. So these data can be, again, just further analyzed to look at if there are any differential care in terms of outcome. And in community care, I'm not as familiar in terms of whether clinical data is being kept in terms of whether seniors receiving community care, how many of them are experiencing wound care, wound and infection and all that, and whether they are getting their clinical experiences in terms of outcomes are the same as those that are not from racialized communities. So all of that is critically important. And in hospitals, because acute and as Notisha said, acute care and complex continuum care and other hospitals, some of them do collect and some don't. And I think it is important, though, to again demand, that if the data be disaggregated, and then so that, because I think it's important to know that the impact of intervention, we call it, right? Intervention, the impact of patient or resident care, it can be so drastically different because of the inherent systemic racism that we are all experiencing, including in our healthcare system, including in our hospital care, in rehab, in CCs, in complex continuum care, in community care. And so it is important to gather that data and be able to then tease out, the impact of those interventions in each of according to race, according to gender, and gender identity, and sexual orientation, and all that. It is so important to, of course, recognize the reluctance, as Notisha and as Anna have mentioned, of the collecting this data and voluntarily or to ask the recipients of care to share this data. And but in long-term care, I have to say that because when we get these data, because it is actually part of the mandate of the home to provide appropriate care, and to recognize that your race, your language, your ethnicity, your culture, your spiritual affiliation, all are critical to you as a whole, as a being. So that's why, clients seem to have less reluctance to fill that out, because they know that to tell them that this is really in order to respond to their needs. So I think it is important for all healthcare providers to look at it that way, because we all know health is not just physical health. All the social determinants of health, as well as all the various dimensions and that we have mentioned, all impact on the intervention as well as in the outcome. And one last point that I also want to mention is that this whole journey of achieving health equity has been a very, very long journey that many of us has been trying to embark on. And I find it probably one of the area that I find most challenging, because it is still very much in control, in the hands of a few white, mostly men. And if you look across the sector, if you look at the decision-making people in the policy realm, be it Health Ontario, as well as the individual providers, from acute care to long-term care to community care, it is still very, very much dominated in the white, English-speaking mostly men. So I think it is so important for us to look at who are in control of this, the human resources side, to ensure that we are not just looking at the data regarding the patients and the residents and the recipients of care, but also the data as to who are providing care and who are making those decisions that are impacting in the delivery of that care. We know the frontline predominantly are people and women from racialized communities, but we know that the decision makers are not. And so we have to get that data, and that there is no excuse, I find, for the providers and for the decision makers, for the government departments, and for all those semi-governmental organizations like Health Ontario, like Health Quality Ontario, like Cancer Care Ontario, like, and all those. I don't think there is any excuse for them not to have equity measures in terms of resources, in terms of human resources, in terms of decision making, in terms of governance levels of governance bodies, and to ensure that there is equitable representation, so that those voices that are not at the table will be added to that table. Thank you.
Great, thank you so much, Amy. So we have a ton of questions. So what I've been reviewing the questions, and I'm going to lump a couple of questions together, and I'm going to ask Dr. Bannerjee if you can answer this one. So this one is around the community fear of collecting data. It could be based on the historical inequities and the historical oppression that those communities have faced, or the distrust of what that data is going to be used for. So what are some ways to address community fear of collecting disaggregated race-based data, and especially given that in the healthcare system, racialized groups and Indigenous groups don't have a good experience in the healthcare system. So what are some ways to address that community fear? Oh, you are on mute.
I think that for Indigenous communities, collecting data, that's CIHR has come up with a policy around working with Indigenous communities, and so you can't go in and do what they did before, and you need a partner who's Indigenous to do that kind of research. And so it's more doing research with the community. I think part of it is they have to start seeing a benefit from being part of this research. Oh, we did a research on the lack of whatever services at the health center, and then as a result of that, the health center gets a new service. If it was that simple. But if they do research, or people are doing research and they can see no benefit for them, then people are less likely to participate. So I think it's really making sure that, and also making sure that the research has representation from the community for the people who are actually implementing the research or the data collection.
Great, thank you. There is a question specifically for Mark. So I'm just going to read that one out, the longer question. So Mark, sorry, I'm just trying to pull that question. Okay, so Mark, you made a reference to a new federal government initiative that's in place to gather disaggregated data based on disability. So can you provide a little bit more information about that program? But like which department is funding it, whether it's a pilot project, how long the initiative will run, and where can our audience get some more details on that particular program?
Good. Okay, very quickly. So StatsCan rely data that we collect on people with disabilities come from 3 different areas. So there's there's something what we call a post-insult survey. Canadian survey on people with disability every 5 years is the primary sources of people with disabilities. It's done once every 5 years, right after the census, and this survey is funded by ESDC. However, many of our surveys also have data to allow the disaggregations of data with people with disability. We have a set of questions, filter questions. We call it a DSQ, which it's an acronym that's basically stands for a set of questions that will allow us to identify people with disabilities. The program I was referring earlier is that starting tomorrow, as I mentioned in my presentation, StatsCan has responded to the pandemic by having what we call crowdsourcing. Crowdsourcing is basically an application that we're going to make available tomorrow to our website, where we invite people to come and answer a questionnaire. The first time we did a few weeks ago, at the beginning of pandemics, we had 200,000 people that participated. So about every 2 weeks, we are launching a specific ones for specific subpopulations. And in all those ones from now on, we ask questions to allow the disaggregation, including people on ethnocultural, immigration. And tomorrow, the crowdsourcing we're going to launch is specifically with people understanding the impact that COVID could have with people with disabilities. So the question will ask specifically how the responded people COVID impacted on the employment, income, household, on health, access to health services for Canadians, especially those with facing disabilities. So starting tomorrow, that survey will be there for 2 weeks. We're hoping that people will come in and answer the questionnaires, and then we hope to have the results at the beginning of August.
Great, thank you. And a question for Amy. So there's a couple of questions around this. So in terms of organizations, even community legal clinics that want to start collecting race-based data, are there some best practices or some guidelines around which they could do this in a sensitive manner, and how can they do it in an effective manner?
I think Notisha has also mentioned that too. I think, first of all, why you are doing this, right? I think it's important to stay upfront, and that should be aligned with your mission and your vision. And if your mission of this organization is to uphold equity in access to justice, right? And ensuring that the recipients of your services are treated, in a fair manner. So I think that sort of language has to be upfront in the organization and in your practices, so that the people who come to you know that, I can trust you in the way that you operate, that I will not be discriminated against because, of my gender or race or whatever, right? So I think it has to be very clearly stated in your organization, and it has to be incorporated in your practice, so that you have the trust and the confidence of the communities, first and foremost. And then, of course, then when you are actually going out and collect this data, of course, you have to be very clear in terms of why you are doing this and what impact would that be, and be open and transparent and say, by collecting this, we are hoping to identify areas that we are not doing as good, and then sharing that all the strategies and reporting that publicly, again, is to show people that you are serious about this, that you have this public accountability built into why you are doing this. And so it has to be part and parcel of what, we heard from Anna, from Notisha, and to ensure that this is not a one-off, right? This has to be included as part of a bigger, strategy and bigger commitment of this organization to make sure that the people do trust you and can confidently share information with you.
Great, thank you, Amy. Mark, there's a couple of questions for StatsCan, so I'll just put it all together. If you can give us a bit of a background as to how StatsCan collects its race-based data. What are some of the principles that you use, especially given what Dr. Bannerjee just recommended? How do you develop your categories, based on ethnicity or race? What does that practice look like? So those are a couple of questions that just lumped together. Sorry, Mark, you're still on mute.
Okay, here we go. That is a very good question, and that's a question that people ask us many times. As I mentioned in my presentation, standards, how we collect data to make sure that they are collected in a standard way, comparable, is very important for StatsCan. And many of the way we disaggregated data, either this is ethnocultural, Indigenous identity, gender identity, or sex, we often rely on the census. And once a census every 5 years set up the process to how this information should be collected and adopted and changed over the years, it's what will set the standards for all our surveys, including the labor force survey. So when we collect what we call race-based data, in Statistics Canada, the recommendation is that our recommendation we tell people is that we have to look at from a different dimensions. One, Stats can collect data based on self-identity. So we have ethno-cultural origins that we ask people, what is your ancestries? So that's one question we ask. Also the dimensions of what we call the population group. You probably heard about the visible minority concept. The visible minority concept comes from the Employment Equity Act. This is the act that Statistics Canada has to respond, and that's the questions, this is the standard question that we ask. Are you Black, white? And this is the standard group. So there were some data that was presented by someone else in the presentations about how they break down the HIV or some data, and they had some population group. So that's a question that allows to do this. And Stats Canada also, because of the Employment Equity Act, Indigenous questions also asked separately. So we ask specifically, are you a First Nations, Métis, or Inuit? So those are the questions. Also, we have also questions and some surveys about religions. We also ask about questions. So when we ask questions about the race-based information, we in Stats Canada will tend to think about, always try, it's not just one simple questions. We want to propose about different ways to answer these questions. Obviously, if some surveys are very limited on time, the question that we recommend is the one that has been used by the census 2016. It's the one that is about our employment equity group, which is what we call the population group. And I think the second question you were asking is, can you repeat the second question again?
It was around how do you come up with the ethnicity categories? Because sometimes it's problematic.
Yeah. So in StatsCan, we have to think about how we collect this information that makes sense for our respondent, and then we have to think about how we're going to disseminate this information. So the collections of the information, the categories, that is, as I mentioned before, it's tied to the employment equity group. So this is what by law, it's not Statistics Canada that made that law, it's the federal government. So those group has been designated by the Employment Equity Act. However, we know that there are some questions about whether or not those categories are appropriate or not, and this is why Stats can try to bring forward other information that we ask. So on ancestry, to be able to understand. And the last, if you go to our centers, to the StatsCan website about the Center for Gender Diversity and Inclusion, one very important piece of information we produced last year and even this year is to present the diversity of the Black populations in Canada. You know, until about 2 years ago, the way that the data was aggregated or presented, and this is what we have to be very careful, is that we can collect the information, but the way you present it is very important. Whereas in the past, we always present Black population as a whole category. The products that we produce is that we want to show that there are diversity among the Black populations in Canada. And then that leads into questions about how should we think about disseminating this information from a different ways that matters more to the communities that the data refers to. So what StatsCan does between censuses, and right now we have started this exercise. We are working right now with funding from the Canadian Heritage and the Anti-Racism Act to rethink about conceptually also how we should disseminate this information, that the categories makes better sense for the community. So we will engage the communities about doing some consultation during the course of this year. We're working with some experts right now, try to figure it out very quickly how we will do this. And then later this year, we're going to consult organizations like yours, or the Color of Poverty, to be able to say, you know, its categories really make sense, so that we can think about the next census, other surveys, what would be make better sense to disseminate this information to new type of categories.
Great, thank you, Mark. So there's a question. I'm going to ask Dr. Bannerjee if you can try to answer this one. So it's around reporting, and sometimes in institutions like universities, privacy is cited as the reason for not reporting and not providing data. So it may be, you know, people asking for the data for research or for advocacy purposes, and being told that because of privacy that they would not be provided this data. Is that a valid reason for not reporting race-based data that institutions collect? Sorry, you're on mute, Doctor.
No, I think as we're trying to move forward, it's really important to collect that data. What's really important is to protect privacy, and especially personal privacy, identifying individuals. There's all kinds of information about protecting privacy, but as far, when you're looking at a population as an aggregate, like, this race of people or that race of people, when there's no identifiers, I mean, Mark can answer these questions more than me. I don't think so. The problem becomes, for example, if you're looking at a population and you're not taking out a population, for example, the Inuit, there's a couple hundred Inuit in Toronto, maybe more, but there's only 38,000 Inuit in all of Nunavut. And if you compare a small population that compared to the rest of Canada, you're going to lose all of those markers. And so I think it's really important to collect that data. And again, you have to say what it's used for, if it's for trying to improve policy, but you have to also do that protecting privacy.
Great, thank you, Dr. Bannerjee. So Amy, there's a question. It's not directly related to race-based data, but I'm going to ask you anyways, as I'm interested in knowing about this. So can racialized seniors and their families afford access to long-term care? So just put it back towards our theme. Is there any data on this in terms of racialized communities being able to access long-term care? Are the waitlist what are the practices of the waitlist? Are they discriminatory, or is there systemic racism embedded within those? And how does that work?
So as I mentioned, long-term care is just inherently a very racist system because the policy, the Ontario government has not pressured, has not made any long-term care home be complying with the spirit of the act, which is, to meet seniors' needs, right? And when somebody lives in a home, this is their home, of course, their language, their culture, and their spiritual practices, and all part and parcel of being a person has to be taken into account. And in Ontario, we pay lip service. It's sort of like in the legislation, but there is no real teeth and no real monitoring mechanisms to make sure that they are really practiced. And as a result, people don't go there, right? Because if you go there and you're to give you a very quick example of why Yihong was set up. Yihong was set up by Dr. Joseph Wong because when he was a resident, he had to visit seniors in long-term care. And one of the Chinese seniors told Dr. Wong that, please help me die. I'm in a long-term care home right now. I do not even speak, there's no staff that speak my language, and I cannot even get a bowl of rice. So this is the devastating, impact of an environment on the seniors who live in a home that just simply do not even recognize his existence, right? So I think it's important to recognize that. And as a result, so racialized seniors, if you're immigrants from outside the country, you don't have the 10 years of residency. That means you don't have OAS. If you don't have OAS, you can't even probably pay that fees. There is a co-payment. It's about $1,100 a month. And then so seniors' families will have to put up that bill, right? So that means immigrant seniors without income resources, very hard to go in to begin with. And as I said, the systemic barriers in the sector. And that's why right now there's no real data to show how many out of the 70,000 seniors, how many are from racialized communities and how many are not? I don't know. I only know the few that are serving the racialized communities like Yihong and Mongshan. The longest waiting list in Ontario are for Yihong and Mongshan, and that list could go up to 10 years to get into bed. That means that these seniors are waiting so long in the community, and I suspect it is also true for other minority communities. So I think it is again, because the data is not there for me to give you a full picture, but this is all based on my experience, and the data is real in terms of the longest waiting list, as well as, of course, the inaccessibility of long-term care. So there's much to be done. Thank you.
Thank you, Amy. question for Mark. So outside of the census, is there any other ways, surveys, or ways that stats can collect race-based data?
Definitely lots. As I mentioned, the questions that we ask on what we call the population groups from the Employment Equity Act or the no cultural. So between censuses, we have the survey called the General Social Surveys that provided a good base of this information. Also, the health community health survey, what we call the CCHS, also collect this information every year. As I mentioned earlier, the crowdsourcing application we started with the pandemic now have all this information so that we're able to disaggregate the data. And the good news I mentioned during my presentation is that the labor force survey, starting in July, will start collating the data about the population group, which is the standard question that comes from the census, which is tied with employment equity. So starting in July, we'll be able to collect this information. And there's also other ways as a StatsCan, when we have health data coming from provinces or justice, when that information can be collected, we have the mechanisms to integrate this data with other sources of data so that we can better disaggregate this information with other informations. So the answer is yes, is that we have different ways of doing this. Can we do better? Yes, because we need sample size to do the survey. So some of those surveys may not have the sample size we want to do, but with proper investments and things, we might be able to disaggregate data further between censuses.
Great. Thank you, Mark. So this is an interesting question. I'm not sure who to direct it to, but whoever thinks they can answer it the best, they can take it. How do you prevent people from drawing biological conclusions? So when they're looking at the data and the health inequities, from the health inequities, how do you prevent people from thinking that this is because of their DNA or their biological makeup?
I think, if I can speak just again, I'm sure Dr. Bannerjee will have more to share. If let's say long-term care or healthcare, right? If you look at because what I'm hoping the data is to show the impact of our care, right? The impact of our systems and the disparities in the intervention that lead to disparities in outcome. Sort of, so for example, like we all know that like the prevalence of diabetes within particular racialized groups, right? And also, unfortunately, if that is the case, and we know that that is the case, so what about the access to diabetic care, right? And what about the support that are required and needed for the communities in order to ensure that they are taken care of in addressing that chronic disease and chronic disease management. So to me, the importance is that to look at the impact and the differential treatment by the system, and as a result, what are the experiences that the different racialized groups are subjected to. So I hope that if that's the data and the spirit and the collection, the objectives and all that, we will not be attributing these results to, just because he's Chinese, then that's why, right? Or just he is this communities, the Asian community, and that's why, right? They are drunk, they are alcoholics, and they are addicts, and that's why, So I think it is really, for me, is like what the impact. And of course, the social determinants of health is that, yes, there are differential, the lack of housing, social, the lack of employment opportunities and all that, all impact on our health. And so all these data has to be collectively presented in that overall picture, and cannot be isolated and singled out in, painting a one-sided thing. At the same time, I want to also highlight what Dr. Bannerjee is saying, that it is not just the collection of data. It is the system change that we are looking at. In fact, there are many, just again, in long-term care, the data will not deal with the systemic, inequities in long-term care, other than the fact that it's not serving the majority of the communities. And just by showing that data, will not lead to that change in policy, that change in the system in long-term care. So I think it is important to bear all that in mind when we are collecting and showing and also utilizing these data.
I agree with what, am I on mute?
Yep, you're good.
I agree with everything Amy has said. I think a lot of it is not just looking at the surface information and digging a bit deeper to find out what are the root causes that led to whatever. It's like saying, okay, you know, like people might say, okay, well, Indigenous people are alcoholics. And, you know, if you look at the data, actually, there are more people that abstain from alcohol that are Indigenous than non-Indigenous. And maybe there are some people who maybe there's higher rates of alcoholism, but then you go and you say in a small percentage, it's a smaller percentage, but then you say, well, why? What happened? What, you know, what are the factors that led to this? Oh, there was residential school. There's the systemic racism. There's the all the other things that have, you know, the fact that they don't have access to clean water, housing, you know, adequate food, you know, maybe there's depression. So I think that if we jump to conclusions like A equals B, and that's just it, and we don't look further, well, actually, you know, those other factors of E, F, G are contributing to that, then we're going to come to false conclusions.
Great, thank you so much. I think we are out of time. We have 4 more minutes, and I know some of our panelists do have to leave right at 4:30, so I'm going to end the questions here. But I know there was several questions for Notisha before she had to leave. So we will forward those questions to Notisha, and if she chooses to answer them, we will post them on the Color of Poverty website. And we can do that for the other panelists if they're willing and if they have time to do that. Obviously no pressure and it's not mandatory. I know Mark said that they will look through the questions and answer them on behalf of Statistics Canada. So thank you everybody for joining us today. And just a reminder, there was a lot of folks asking for guidelines and best practices in terms of collecting race-based data. And I just wanted to redirect people to the Color of Poverty handouts that are attached to the webinar on the right panel, the 5 handouts there. And then you can also go to the Color of Poverty website. There's a lot more tools there that you can use when you're beginning to collect race-based data for your organization. I'm sure a lot of them will be handy. And also you can connect with us at Color of Poverty. So Michael Kerr, who's the coordinator of Color of Poverty, I'm sure he wouldn't mind getting emails from folks that are looking to be pointed in the right direction. So thank you again, everyone, for joining us today for our Race Matters webinar. I wanted to specifically thank our 4 panelists. I know Notisha is not here with us, but thank you. I know at this time, everybody is quite busy and more so now because of COVID in their everyday jobs, in the advocacy that they're doing, and in trying to do a lot more to support our communities. So thank you for taking your time out to be with us today and to answer our questions. I also wanted to thank, on behalf of the Color of Poverty, Color of Change Steering Committee, our organizing team. I know they're kind of in the background, but your efforts are going to be acknowledged, whether you like it or not. So Amy Kasipulai from OCASI, AV Go from the Chinese and Southeast Asian Legal Clinic, and Michael Kerr, who's the coordinator of Color Poverty of Color Change, for putting this webinar together. We are going to be sending a quick evaluation. It's a very short survey. It's just 3 questions to get your feedback after this webinar. We would really appreciate it if you can fill that evaluation piece out, just so that it can help us plan for the future, what kind of events we want to do and how we did with this one. And again, just a reminder that this webinar is being recorded. It will be posted on colorpoverty.ca. And we will have the slides from Statistics Canada in both English and French available on the Color of Poverty website. So thank you everybody once again for joining us, and we hope you have a great rest of your week.
Thank you very much.
Thank you. Take care.
you very much. Thank you very much. Bye-bye.
Bye.